So if you're doing an arthroscopy and you planned an ACL reconstruction for a case and you're viewing the knee, left knee from an anterolateral portal, assuming that this patient is not a COPA and has been offered surgery for anteroposterior instability, if this is the picture you see intraoperatively, where the ACL has just peeled off the femoral footprint, what would be your next steps? So the treatment options in such a case are, you could either go ahead with a remnant preserving anatomic ACL reconstruction, but in this case, it would be more of remnant destroying, because if you're trying to stay within the anatomical landmarks, then you would have to destroy a few of the original native bundle fibers too. The other option was that you leave whatever is in the anatomic position as is, and you supplement it, augment it with a graft or a tape. But if it's not going to be where the original structures are, that means it's going to stay non-anatomic. And the third, the seemingly sensible option here seems to be an anatomic ACL repair, where you have the anatomy intact and the place where it's come off from, you just fix it back there. So what is needed for an ACL repair? An arthroscopy surgeon would probably first need evidence. So in our heads, we need to be convinced if an ACL repair actually would give us the result similar to or better than an ACL reconstruction for such cases. So recently, there's a cadaveric study published by Jorge Chala and his group that talks about a kinematic analysis of anterior cruciate ligament repair versus a reconstruction. And the graph is pretty much self-explanatory, that if you see between 15 and 30 degrees, there is an anteroposterior displacement of around 10 mm, or just about more than 10 mm. That's like a Lockman when the knee is ACL deficient. If you go on to repair or reconstruct it, then you get graphs that are very similar to an intact ACL. In fact, you can see that the graph of the repair is closer to the intact ACL graph than the reconstruction graph. So there are not a lot of studies published, but now there has been 2 to 3 randomized controlled trials as well. And a meta-analysis tells us one thing for sure, that ACL repair is safe. The failure rates may be slightly higher, that's between 7 and 11% vis-a-vis an ACL reconstruction, probably having a failure rate between 3 and 5%. But it is no lesser in terms of functional outcome scores, and the knee can get back to the same stability that it had before the ACL was intact as well. So one, you need evidence to offer a patient an ACL repair. That's convincing yourself. What else is needed? In the OR, you need inventory. So most of us, especially in India, if we go on, if you're doing an ACL reconstruction, all the inventory would probably include stuff that would be needed for a multi-ligament case with meniscus or cartilage injuries added as well. So if you wanted to do an ACL repair, you'd need stitching material, which you'll have because you would have inventory in place to repair the meniscus in case you found a tear during the scope. Second, you'll need stitching devices. So something like a first pass mini used to repair meniscal roots is always in place in the OR. You could probably also need augmentation material, which you'd also have during a standard ACL reconstruction case. Lastly, for all the reports, all the papers that have been published for primary ACL repair, we've seen the authors use fixation devices, suture anchors, which probably may not be present in a standard ACL reconstruction case in the OR, probably present during shoulder arthroscopy cases or at a big institution where they have a huge inventory log. So the question arises, if you see something like a femoral peel off of the ACL during a scope and you don't have a suture anchor with you, how do you go on to repair an ACL? So we've described an economic primary repair of the femoral sided avulsion, which doesn't need suture anchors. So now we have a log of 4 cases with 18 months of follow-up. This is the same case where it's the left knee with the femoral sided peel off. We're viewing from the anterolateral portal and working from the anteromedial portal. At some point, you also have a central Gilchrist portal, which helps with better viewing. So you take high molecular weight polyethylene sutures through the remnant bundle from one working portal. Then you shift the viewing portal and go on to view from the medial side. And this is the first pass mini with a different colored high molecular weight polyethylene suture. And we are taking suture tags around the existing remnant in such a way that obviously you have to try and avoid capturing the PCL fibers or the synovium around that. And you have to avoid scuffing cartilage in the entire process. Once these sutures are taken, they are all pulled together in a way that we have access to the femoral footprint. And after taking just an entry, we can use the sutures to pull the ACL remnant away and use a 4.5 mm drill bit to try and drill through and through the lateral femoral condyle and come out on the lateral femoral cortex, but drilling between the ACL and the PCL to protect the remnant. All the sutures at the end are then shuttled out through the lateral femoral condyle, out on the lateral femoral cortex. And this is through the 4.5 mm tunnel that has been drilled in the knee. Once everything has been shuttled out, it can be fixed using a suspensory fixation like a suture disc on the lateral femoral cortex. More importantly, this can be fixed in extension. Unlike a suture anchor, when we're using a suture anchor, due to access issues, we need to fix the ACL in flexion. But here, we can extend the knee, and just as we fix the graft in an ACL reconstruction closer to extension, the same thing can be done for repairing the ACL primarily. So the indications for a primary repair are adults, because adolescents have higher failure rates as far as established evidence is concerned, femoral sided avulsions, acute tears, maybe less than 6 weeks, where the tissue quality seems to be appropriate and adequate. We haven't discussed another indication where, in case you have a rare soft tissue tibial sided avulsion, like you can see in this picture, not a bony avulsion, which of course you can go on to fix, but a soft tissue avulsion that's acute in adults. We've described it. We can also go on to repair that primarily in a very similar fashion to the video just shown earlier, where you can take those bundle sutures, bring them out on the tibia and tie them over a suture bone bridge or a suture disc. The new kid on the block is bridge enhanced ACL repair. And this is for one of the standard traditional contraindications from a primary repair. That's a mid-substance tear. So for a mid-substance tear, there's a huge gap that forms between the proximal and the distal ends of the ACL. And now there is some evidence that if you have a sponge or something that can actually act like a conduit between the two ends of the ACL, and we can somehow enhance the healing process of the ACL between the two ends using the sponge, then the ACL can repair on its own, even if it's torn mid-substance. So Murray has really championed the cause for these bridge enhanced repairs, and hopefully this is something that we'll be looking at and discussing more often in the near future. So the conclusions of this talk are: number one, when we talk of ACL repair, overhauling primary ACL reconstruction, we need to for sure say that ACL reconstruction is still the gold standard. Two, the role of repair is definitely on the rise. And the current indications are an acute femoral sided avulsion in adults with good tissue quality. These are the patients where we must try and preserve, protect anatomy and proprioception, knowing in our heads that the evidence says that the results of repair are as good as a reconstruction. Thank you.